Okay, so in this video, we'll be talking about acute severe asthma, previously known as status asthmaticus. In this video, we'll talk that what is status asthmaticus? How do you assess the severity of status asthmaticus? And if a patient comes to you in emergency department, how do you classify a patient with acute severe asthma? And how do you manage it in emergency department? What is acute severe asthma? Acute severe asthma is an exacerbation of asthma which is unresponsive to standard bronchodilator and steroid treatment. This patient is a diagnosed case of asthma and he is presented to you in emergency department with acute exacerbation, and you try to treat that patient with standard bronchodilator and steroid therapy, but that patient is not getting better. That is called as acute severe asthma. Presentation of such patients will be they will be breathless and the chest will be wheezy, their respiratory rate will be high. And in the history, the most important things that you need to ask about is you have to ask about their usual and recent treatments that they are receiving for their asthma, and you have to ask about the previous acute episodes and the severity of those previous episodes. You have to ask about their best peak expiratory flow rate. What is peak expiratory flow rate? We'll discuss it in a while. And you have to ask that whether they have been admitted in ICU before for an acute exacerbation of asthma or not. These are some important questions that you need to ask about. How to assess the severity of asthma? You assess the severity of asthma by a device called as peak flow meter. Peak flow meter, patient exhales, and by exhaling you record the peak expiratory flow rate. Since asthma is an obstructive disease, in obstructive disease the expiration is obstructed, so you can spot that out on peak expiratory flow rate. You can check their ability to speak, whether they are able to complete their sentences or not. You can check their respiratory rate. Their respiratory rate will be high. And you can check their pulse rate. You can check oxygen saturation. Their oxygen saturation will be low. These are the things that help you assess the severity of asthma. And if a patient comes to you in emergency department, you are assessing the severity of the attack. You classify them into two categories. One is severe acute attack and the other one is life-threatening asthma. Severe acute attack is the one in which patient is unable to complete sentences in one breath. Patient will be unable to talk. He will be taking pauses while completing a sentence. Respiratory rate will be greater than or equal to 25 per minute. Pulse rate will be greater than equal to 110 beats per minute. Peak expiratory flow rate will be from 33 to 50% of the predicted are the best. So this is a patient who is having severe acute attack. On the other hand, if the patient is having life-threatening attack, that patient will be exhausted, that patient will be confused, and there will be a feeble respiratory effort, or even sometimes the chest will be silent, there will be no wheezes. So this is not something to be happy about, that the chest is not wheezy now, maybe the treatment is working. Sometimes that patient has developed silent chest, and that silent chest is very life threatening. So that silent chest or feeble respiratory effort is a life threatening attack. If the patient is having arrhythmia or hypotension, or peak expiratory flow is even less than 33%, compare it with this side where it was from 33 to 50%. In life threatening attack, it is even less than 33%. And arterial blood gases show normal or high PaCO2. Remember, a patient presenting to you in emergency department with acute severe attack will be tachypneic, and tachypneic patients should have the low carbon dioxide level in the blood. That low carbon dioxide level in the blood is better than a normal carbon dioxide level or a high carbon dioxide level. Why? Because after some time these patients develop respiratory fatigue, their muscles get fatigued and their respiratory effort slows down, and when their respiratory effort slows down, carbon dioxide retention takes place, and that carbon dioxide retention first present as normal PaCO2, later on it presents as high PaCO2, which is alarming that patient is developing severe life-threatening attack. SaO2 saturation of oxygen will be less than 92%. So these are all the signs that that patient is having a life-threatening attack. Based on these severities, we manage the patient. Now, immediate treatment that you need to give to such patients is that you have to give supplemental oxygen, and you try to maintain this oxygen saturation between 94 to 98%. With that, you give salbutamol 5 mg or terbutaline 10 mg nebulized in a nebulizer with oxygen. So you are giving oxygen and you are giving a bronchodilator. After that, if the patient is having a severe life-threatening attack, you also add ipratropium bromide. Ipratropium bromide is an anticholinergic drug that causes bronchodilation with the dosage of 0.5 mg per 6 hours to the nebulizers. Asthma is an inflammatory condition resulting in inflammation of the bronchi and bronchioles. So you have to give steroids to reduce that inflammation, reduce the damage due to that inflammation, and you give bronchodilators to fight that constriction. You dilate the bronchi and bronchioles and you reduce the inflammation by giving steroids. You give hydrocortisone 100 mg IV, or you can give prednisone 40 to 50 mg orally, depending upon the severity. Other than that, while you have given these two things, you maintain the oxygen saturation, you look for the vitals, you check heart rate, you look for the respiratory rate, and you look for peak expiratory flow rate, whether there is any improvement in the condition or not. If the patient's peak expiratory flow is less than 75%, you repeat the salbutamol nebulizers with ipratropium bromide every 50 to 30 minutes if that patient is not improving and the peak expiratory flow is less than 75%. And you also monitor ECG for arrhythmias, because arrhythmia can quickly kill the patient. So you need to look for arrhythmias frequently. Mostly these patients who are having acute severe asthma do not respond to the standard therapies of steroids and bronchodilators. So these patients need a single dose of MgSO4 1.2 to 2 gram IV over 20 minutes. In those who are having severe or life-threatening features, these patients should be given MgSO4 because MgSO4 causes bronchodilation and it is very effective in controlling severe and life-threatening asthma. So what are the outcomes when you are trying to treat the patient with steroids, oxygen, bronchodilators, and magnesium sulfate? These patients can get better. If their peak expiratory flow gets greater than 75% and their vitals are now stable, these patients can be sent home. You need to send them home, and while you are sending them home, you need to give them metered dose inhalers containing bronchodilators, and you need to give them oral prednisone for 10 to 14 days. Since these patients had an acute inflammation exacerbation, these patients must be given prednisone for 10 to 14 days, which is tapered off and stopped later on. Metered dose inhaler is continued when needed, whenever the patient is having an attack. These oral prednisone reduce the inflammation. On the other hand, patient can develop deterioration in the peak expiratory flow. If the patient is developing deterioration in the peak expiratory flow, there is carbon dioxide retention, patient is having hypoxia, respiration is feeble, chest is either silent, or patient is developing respiratory arrest, or the patient is now developing altered consciousness. This is a very severe patient, and this patient must be shifted to ICU now. This patient should be shifted to ICU, where there should be continuous nebulization, and that patient must be put on ventilatory support. Intubation should be considered because these patients are not going to make it without ventilatory support, since they are not responding to the treatment. If the patient is developing recurrent episodes of acute exacerbation of asthma, there are few things that you need to look for. You must look for non-compliance with the medication. Some patients are non-compliant with the medication, therefore resulting in acute exacerbations. Other than that, few patients have poor inhaler technique. Like whenever they are developing asthma, they have poor inhaler technique. They cannot use inhaler properly and the drug is wasted. Such patients should be trained with spacer. Such patients should be recommended the use of spacer. Spacer is device like this, which is attached to the inhaler. Inhaler is attached on this side, and spacer is present over here. So when you give the drug, that drug is present in the spacer, and that patient inhales. So even if the patient cannot inhale the drug completely in one breath, that patient can inhale the drug in the second breath, and that drug is not wasted. That is present in the spacer device. So spacer use must be recommended in such patients who are developing acute severe exacerbations and there is a poor inhaler technique. In summary, we talked about what is acute severe asthma, how does it present, what are the points that you need to take in the history. Then we talked about assessment of the acute severity of asthma by peak expiratory flow rate and certain factors, and classification of the patient based on those factors. What is the immediate treatment? Oxygen, salbutamol, and steroids. And if the patient is not responding, continue nebulization with salbutamol and ipratropium, monitor ECG, and give MGS support. Outcomes: if the patient's PEF is greater than 75, send them home with MDIs and oral prednisone. And if the patient is deteriorating, send them to ICU. If you liked my video, please click on the subscribe button and check out my other videos on emergency treatments. Thank you. Link of those videos is given in the description below.